Hi, this is Dr. Michelle O'Donoghue reporting from Medscape. Joining me today is Sunil Rao. He is a professor of medicine at NYU Grossman, as well as director of interventional cardiology at NYU Langone. Welcome, Sunil. Thanks for joining me today.
Yeah, thanks for having me.
So one of the more interesting trials that was both published last year in the New England Journal of Medicine, and then also we have a subgroup analysis that's being presented tomorrow at ACC 2024, is from the MINT trial. So I guess before we get into this new substudy from MINT, let's maybe take a step back and think about strategy trials in general in terms of thinking about transfusing people to a higher hemoglobin level versus just leaving people with anemia. Like we've known for years, right, that lower hemoglobin is associated with worse outcomes, but the question mark has always been, do you transfuse people up, and does that translate into better outcomes?
Yeah, I think you framed the question perfectly. I think there's been a lot of historical data that suggests that we should maintain the hemoglobin at 10 in patients who have coronary artery disease. There are observational data from patients who, for example, refuse transfusions because of religious beliefs that suggest that even in patients undergoing bypass surgery, you can push their hemoglobin down to 6 without any sequelae. So the question has always been not whether we should give a transfusion, but how much we should give and what is that transfusion trigger. Based on observational data, the two triggers that have kind of emerged are a hemoglobin of 8 versus a hemoglobin of 10. There have been plenty of randomized trials, as you've noted, in other settings, critical care, infectious disease, even GI bleeding, suggesting that a so-called liberal or aggressive transfusion strategy is really no better than letting patients ride at a lower hemoglobin. Interestingly, most of those studies, in fact, probably all of them, have really excluded patients with acute coronary syndrome. And the acute coronary syndrome setting, one can imagine a rationale for pushing the hemoglobin higher because, hemoglobin is part of the oxygen delivery equation. These patients have already manifested some kind of hypoxic insult with an acute myocardial infarction. So potentially maintaining a higher hemoglobin should be beneficial. The flip side, of course, is that transfusion or packed red cells that are stored are not the same as the red cells that are in our bodies. They're depleted of nitric oxide, 2,3-DPG. They may not, in fact, deliver oxygen very well. There are some data suggesting that there may be some platelet activation as well, so there's potential for harm. So that is really what set up the MINT trial, which is an NHLBI-funded study of 3,500 patients with acute coronary syndrome, acute MI, and all kinds of MI were allowed in this trial, type 1s as well as type 2s. And they were randomized to maintain a hemoglobin of 8, the so-called conservative transfusion strategy, or maintain a hemoglobin of 10, so-called liberal transfusion strategy. And interestingly that we use those terms in today's political environment, but that's exactly the terms that we used.
And what did the primary results of MINT show?
Yeah, so it's really kind of a fascinating study. It's the largest randomized trial in this particular population. And, the trial just barely missed conventional statistical significance. So we had to conclude that really there was no significant difference in terms of the two strategies, but all of the point estimates really lined up on the side of liberal transfusion, that was maintaining a hemoglobin of 10. Cardiac death, which with the caveat was not adjudicated in the trial, actually favored the liberal transfusion strategy. So I think from a pragmatic bedside standpoint, it does seem that a more liberal transfusion strategy probably is beneficial in patients with acute MI.
Yeah, I think that MINT was very interesting in the sense that, yes, overall it was neutral, but certainly a very strong signal towards there being benefit. So you started to discuss this, but how do you reconcile that with prior studies that have not been in the ACS state, that have not suggested that a liberal transfusion strategy would be beneficial?
Yeah, that's a great question. And if I could extend your question a little bit, how do we reconcile it with the prior observational data? Maybe that's an easier question to answer because the observational studies, and certainly I've been a co-author on many of them, are probably confounded by indication. And there's just no way to unravel that in the observational setting. You have to randomize. I think there are fundamental differences in the acute MI between the acute MI population and the other populations that were studied. My guess is that one size doesn't fit all when it comes to transfusion strategies, and that acute MI population probably is a particularly special population that, again, has already manifested some kind of an ischemic insult with their acute MI.
So here at ACC, there's an important subgroup analysis that is being presented and looking at type of MI that was enrolled. So type 1, type 2 MI, it's interesting that there was a pretty even split between the two in MINT. And I have to say the results of the subgroup analysis are somewhat counterintuitive to me because it suggested that there was greater benefit in patients with type 1 MI and really kind of neutral benefit in the type 2 patients. And one might think that with a supply-demand mismatch, that there really the supply question would be answered by a more liberal transfusion strategy.
I think that's exactly. We were surprised as well. Now, again, it's a subgroup analysis of an overall neutral trial. All the caveats apply. But it is interesting, isn't it? I mean, the type 1 MI, so-called plaque rupture, not the supply-demand mismatch, are the ones who benefited more, if you want to use that term, from a liberal strategy. So again, there probably are differences between those two patient groups. It's possible there are some competing risks in the type 2 MI population. But I find this really fascinating, and I think it sort of goes in that category of other recent trials that are really calling into question what our fundamental concepts of physiology really are. And I think there's probably going to be a lot more data coming out about type 2 MI in general that may help to put some of these results in context. But the type 2 MI population is really interesting to me because it is a very heterogeneous population. And it's possible that, again, one size doesn't fit all when it comes to transfusion. There may be some patients who benefit from a more aggressive transfusion strategy. So, for example, if their ischemic event is precipitated by anemia, then maybe there's a benefit. Right now, though, based on the MINT trial, I don't think we can actually make any conclusions about the type 2 MI trial, type 2 MI patients, because the benefit does seem to be concentrated in the type 1 MI patients.
And if there truly is benefit in the type 1 MI patients, the pathobiology is interesting there too, because I would imagine that most of these patients were revascularized. And so does it suggest that there was some ongoing ischemia that the liberal transfusion would in some way benefit or ameliorate?
Yeah, I think that's the hypothesis. Now, we are diving very deep into the revascularization population. We're hoping to present those data later this year. Again, that's non-randomized. So there are patients who are, of course, going to be selected for revascularization. And as you can imagine, they're in this overall population of trial patients that are very, very sick. I mean, these are older patients. They have a lot of comorbid conditions. The ones who were selected for revascularization were a little bit healthier, as you can imagine. So there's going to be a little bit of work to untangle all that, but we hope to have more data on that a little bit later this year.
Great. No, that'll be an interesting one. So in terms of key takeaway, what do you do right now in your clinical practice? Because the other thing to factor in as well is that blood is not an infinite supply. It's not always easy to, think about how to allocate those resources.
Yeah. And again, it's a great question because I think if you were to implement what we think are and again, the trial group led by Jeff Carson think is the right message from MINT, it has larger implications than the patients that we're treating. There are societal implications in terms of blood supply, cost issues in terms of more aggressive transfusion. I can tell you that I think based on a lot of the observational data, many hospitals have put into place guardrails where no transfusion is allowed unless the hemoglobin is less than 8 in an acute MI patient. My personal opinion, and I'm certainly not speaking on behalf of any organization or any group, I think that's probably wrong. I think that we probably do need to think about using maintaining a higher hemoglobin in acute MI patients. So we're actively having discussions at our hospital, for example, think about how do we alter our algorithm for patients who are anemic, who come in with acute MI. But again, those conversations are going to be nuanced and very complicated as we think about the blood supply.
Well, it'll be interesting to see what else we can learn from MINT as more subgroup analyses get presented. Thanks again for joining me.
Thank you.
Signing off from Medscape, this is Dr. Michelle O'Donoghue.